This episode of the Modern Therapist Survival Guide is brought to you by Superbill.
Interested in making it easier for your clients to use their out-of-network benefits for therapy? Superbill is a service that can help your clients get reimbursed without having to jump through hoops. Getting started is simple. Clients complete a quick HIPAA-compliant sign-up process, and you send their Superbills directly to us so that we can file claims with their insurance companies. No more spending hours on the phone wrangling with insurance companies for reimbursement. Superbill eliminates that hassle, and clients just pay a low monthly fee for the service.
Stay tuned for details on Superbill's therapist referral program and a special discount code for your clients to get a free month of service.
You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt and Katie Vernoy.
Welcome back, Modern Therapists. This is the Modern Therapist Survival Guide. I'm Curt Widhelm with Katie Vernoy, and this is the podcast for therapists that explains and explores a lot of things that we don't necessarily get in our trainings. And rather than just waiting for clients to show up to our office and make us have to learn things or hope that we know everything about our clients coming in, or in some cases where clients might not be coming in due to some certain factors. We are being joined today by Dr. Alan Lipscomb, an LCSW. We had made reference to him back in our conspiracy theory podcast a couple of months ago, as far as having a particular method that we'll get to a little bit later in this episode here. But Dr. Lipscomb, we found out after that episode, he's an associate professor at Cal State University Northridge, where I also teach. So always kind of cool to see how our communities come together. Thank you very much for joining us today, Dr. Lipscomb.
Thank you for having me. Excited to be here.
We're so excited to have you here. I was reading through the BRA method that you put together. I really liked the things that you had to say in that conspiracy theory article that we had referenced before. Just so excited to talk with you today and pick your brain a bit. But we always start with all of our guests with the question, who are you and what are you putting out to the world?
Absolutely. I am the Black male grief researcher. I am a clinician. I am a professor. I am a father. I am a partner as well.
And we are starting out the conversation in talking about working with Black male clients. And in case people haven't noticed, therapy's been pretty white for a very long time.
Absolutely.
And this is a population that might have some reservations about seeking out some services. What are we getting wrong as a profession that's making it to where it's creating maybe some unnecessary barriers to being attractive to Black males as far as clients and wanting to seek out services? And once they do show up, is there things that we continue to do wrong?
I love so much this question, Curt. Yes, I think the first thing we're getting wrong is this whole narrative that Black males are not wanting or coming in for services and therapy. One of the things I found out fairly quickly when I went into private practice, I still maintain a small private practice, is that was the number one population that I started to see in a private practice setting were Black males. And I said, wait a minute. This went against everything I learned in my graduate program. There was a lot of information and research around resistance and there being trepidation in coming in and seeking services. So when I started to see a lot of Black men coming in for therapy, and underneath that, regardless of why they were coming in for services, I found that there was this underlying grief piece, unresolved grief piece. And so I think going back to your second question is, what do we get wrong when they come in? I think we're not prepared for them to come in. So then we don't know how to hold the therapeutic space, assess, provide services and treatment that are culturally responsive.
With this grief, and I think you described it in the questionnaire we sent over as Black male traumatic grief. Can you talk a little bit about what you're referring to there?
Absolutely. So when we think about traumatic grief among Black men, it is due to racialization. It is race-based trauma. So George Floyd, Ahmaud Arbery, Trayvon Martin, right? So on and so forth. That has an emotional and psychological traumatic impact on other Black men and youth who were exposed to it, who hear it, who view it on social media.
So for those of us who got the grad school experience of, wait, they are actually going to show up to therapy, can you help us with what do we do? What can we do better to help support clients who are facing this kind of traumatic grief and actually promote health and healing in this process as we welcome them into our practices?
I think in the initial phases of services and treatment, that engagement and rapport building, it's really about slowing yourself down enough to honor, support, and respect what they're sharing, even if it doesn't make sense in our own view based on our positionality, social location, and intersectionality. One of the things I found for non-Black folks who are providing clinical services to Black folk, specifically Black men, is they feel like they have to provide them a referral to a Black male therapist. Because they are white, because they might be Asian, Pacific Islander identified, et cetera, they don't believe that they are the best person to provide services. And I think that's a mistake too, because who's to say that you cannot be clinically effective just because you do not identify racially as Black men who may be coming in receiving services.
So if we don't refer out, I think there's a fear that the lack of lived experience or the very different lived experience, maybe is a more appropriate way to say it, will get in the way of being able to be present, to be empathic, to really understand the experience. What do you say to that?
I say you don't have to understand something to hold space for something. One of the examples that I use with my students is that as a cisgender male, I will never know what it's like to have miscarried. I will never have that lived experience. But can I provide support with compassion, empathy, and respect for a woman who has miscarried? Absolutely. Do I have to refer her to another female therapist who had an experience with a miscarriage? Absolutely not. It's how we hold the space and connect with the felt experience that's showing up in the room that allows for Black men and people in general to feel like you get it. You're connected to the felt experience, and we're not questioning their truths to investigate, to interrogate, to deny, or to make you teach me to get it. That's the other setup, is that we don't want to put specifically Black men in the position to have to teach you how to support them in the space. It's truly about listening and honoring and not moving quickly. One of the other things we get wrong, going back to the question that Curt was asking, is we don't allow for Black men to emote in the space. And this is everyone. This is Black folk who are clinicians as well. We have learned as a society to mitigate it, to rescue it, to try to make sense of it, whereby truncating their bereavement emotive experience in the space that they're sharing. So I tell folks, slow down. When I provide trainings around Black male grief, when we start to see fluctuations in feelings and expressions, that's your reminder to take a beat, allow for that. And they will traverse their own grief and emotive experience.
So what I'm hearing is treat them like they're humans. And
that
like
part.
they get a human experience.
100%. 100%.
And it's interesting because I remember back to the day in my cross-cultural class when I was in grad school that talked about working with Black clients. Yes, the one day. And,
that part. The one day, the one class.
Yes, exactly. That talked about almost the opposite of what you're suggesting, which is that if Black clients are coming in, you should give them a very structured and formal idea of how long treatment and action is going to take, so that way they can predict how they're going to get out of treatment.
And I think that's the setup, right? And what I like to do is go critical, go a little bit deeper and say, well, where are we getting this information from? How do we know that we need to do this, right? Have we talked to and spoken to Black folks who are receiving services? That's what started me on this whole Black male grief journey, is that one, I found that this was one of the number one unresolved issues that I was seeing across the board with Black men. And two, when I looked at the literature and research around Black male grief, it didn't exist 8-9 years ago when I started off on this journey, right? It's like, what do you mean Black male grief? Grief is grief. And there's still folks who believe that grief is grief. There is no difference. And what I have found over the past 8 years is that it is different, and it does show up different, specifically around Black male grief.
There's so many different places to go with this. I have, so many questions. I'm going to try to pick a question here, and then we'll probably get back to the other ones in a little bit. But I think the first one is really looking at believe the client's experience, be present, slow down. And we first mentioned your work related to conspiracy theories and how those things can show up. And so I'm very curious on how you hold both of those things, especially towards the beginning of treatment when you're just getting to know someone. It seems like there's a lot that could be there. So maybe I'll start with that question, and then we'll keep scooting around because there's just so much I want to ask.
Absolutely. So when you're first beginning services and engaging, specifically when we talk about conspiracy theories, we don't know enough about who that person is to determine at that initial intake session if this is truly a conspiracy theory. Is it rooted in psychosis? I mean, yes, it depends on if there is psychosis here, right? Hallucination and delusions. We can pick up on that rather quickly because of our training and skills. But what I'm touching on, it's more about the lived experiences connected to racialization and trauma and the mistreatment of Black folks that can lead to these conspiracy theories related to, I don't know what they're putting into my body. I don't want to go and get vaccinated. Well, talk a little bit more about that, right? Notice I'm not saying help me understand, because I may never understand that, right? Talk to me more about that. Right? When did you first notice this? Right? I tell my students, do FIDO: frequency, intensity, duration, and onset. When did you first start having this experience around people putting things in your body? When was the last time? How often does it happen? So on and so forth. And what we're assessing for is, one, listening to their narratives. Two, what are the themes and patterns? And is it impeding upon their functioning and overall well-being? That's when we have to go a different route with it. That's when it's concerning as it relates to their mental health.
Well, I think the follow-on question is, how do you know if it's a conspiracy theory or somebody really out to get you? I mean, I think those are the things that, especially in being a white person working with a Black person, I think that there could be a tendency, if I'm not just exploring the lived experience, where if I'm showing any doubt, I mean, part of that could be bias, part of it could be something else, but it also, I think, could be really invalidating for the lived experience. And so I don't know if you have any suggestions on how to walk that line for non-Black therapists.
Wonderful question. Assess for how their community and kinship are responding to that narrative. What do I mean? Ask them, have you spoken to your family about this? How have they responded to this? Do they support you around this? What does your community, like if you're a part of a church, et cetera, how have they responded? Because that's what you will start to suss out and find out. Is this culturally connected and relevant or not? Because if the kinship and family community is saying, no, this is all in your head, there we go. That's information for us.
That makes sense. Thank you.
Now, one of the things that I'm noticing as you're talking about this is it's also very much in the way that you're presenting these questions. And you made mention to this in interviews that we've seen you do with other people, if we acknowledge that other people get your time too. But just in this still very supportive way, that it's not just kind of like, when did these onset, that ends up making it be challenging and confrontive, that is invalidating to the client's experience, that it's very much in still creating that positive, nurturing environment there too.
This is why I came up with the whole BRA approach, right? The bonding recognition to promote understanding and healing is to truly honor people. And this is not anything new. This is trauma-informed care. right? This
Sure.
is healing-centered engagement, right? I didn't invent this, family. I am just saying we have to be intentional when we are holding the spaces. So the three questions that I continue to ask myself as I'm formulating my thoughts and engaging in services with Black men is the way in which I am about to ask this question, is it honoring? Is it hurting? Or is it hindering? Could it hinder them? Could it hurt them? Right? Is it honoring? Or is it helpful to them? These are things that I kind of think about. It also allows me to pause and slow down, to engage in more mindfulness, intentional practice when I'm providing clinical services versus just engaging whatever comes to me and going with my gut in the moment, right? Maybe I need to take a beat and take a pause. I think this goes back to the questions you were asking earlier regarding where we get it wrong. I think we also get it wrong when we don't consider who we are as clinicians in the space with them. Gone are the days where we cannot talk about how they're experiencing us as the provider of mental health services based on who we are intersectionally speaking. So at the end of my sessions, I will ask my clients, how was it for you to meet with me today? And usually they'll say things like, oh, it was fine. It was cool. It was whatever. And I'll say, good, I'm glad. How was it for you to meet with me as another Black male in the space? Oh, it was fine. It was okay. It was whatever. Okay. If ever there comes a time, because although we may identify as both Black males, there may be something that I might miss because of my own experience or lack of experience. Please know that we can talk about it throughout the time that we are working together in this therapeutic relationship. How does that sound to you? Now, you don't have to be a Black male therapist to insert that. It's acknowledging I represent something and I recognize you may have an experience of me. And guess what? We get to talk about it. I'm okay with that.
I like that. And I also know that there are some therapists who are afraid to bring up race when they don't share the race of the person that they're working with. And I know I've claimed it on this episode, or not this episode, on this podcast, that like there was one time I tried it and it was with an Asian American family, but I was just like, and it was a big old mess. And so I think, and maybe this is just to kind of acknowledge that sometimes bringing race into the room feels very challenging for folks, non-Black folks, especially, I think. But I've heard over and over again, and I've experienced this in the work that I've done subsequent to some of this new learning, that it actually is a relief or it's a non-issue. And so I don't know if you have more to say about that, but I think it's something where I know for myself, I get that little bit of nervousness of like, this is a thing. And then it's usually a really interesting conversation and a way to connect. So
100%. You know, it's affirming. It's affirming to have someone, let's go with what you were sharing. It's affirming to have someone who is white in a position of power to say to me, hey, I recognize that we are racially different. And I also recognize that we could have a different experience about how that shows up in this space.
Yeah.
I'm okay with talking about it because as a Black man, I don't know if you want to or if you're able to talk about it. So guess what? I am never going to bring up your whiteness in the space.
I've mentioned on the previous episodes here as well of working with teenagers in my practice that when Black clients, usually parents, are on that intake phone call with me, one of the questions that I ask in that intake phone call and then also in the first session with the teenager is, do you have any concerns about working with a white therapist? And what I'm hearing out of this is that that's not the only time to have that conversation, that's a continuous conversation and one that continues to need to be led by therapists to make it open until it's naturally happening.
Absolutely. It should be integrated. There are times where I'll leave a session, and many of my fellow therapists can relate to this, and you're driving home and you say, oh my gosh, I missed it. Ugh,
yep.
I missed it.
Yep.
Ugh. Okay. That next session, you get to come back and address that. And so I'm saying that to say, even if you don't do it in the moment, but you catch it after, you get to come back and bring it in and say, I noticed you shared something last week and I think I missed it. I think this is where our identities came up last week in our session, where I did not catch, and I want to come back to that. Authentic, it allows for trust and rapport to be built in a different way. It's like, wow, you get it, you caught it. Absolutely.
In a training that I went to, and I don't remember exactly when it was, and I don't know how well it was put together. So I'm going to ask this question from you. Is there, you were talking about kind of allowing space or holding proper space for the expression of grief. And when you were talking about identities, it just popped in my brain that as a society, we fear Black male emotion, especially big emotions. And I've heard, I think in some of these previous trainings, that there is an impulse or an instinct or a perceived need, I don't know exactly, or potentially a real need for a Black male client to protect their therapist from their emotions. And I know in some of the interactions that I've had with Black men that there are times when I feel like I'm getting a veneer of very nice, very kind, very smiley man, non-threatening man. Hello, non-threatening. And I feel like that must show up in therapy with folks who are sitting cross-culturally from a Black male client. And so I don't know if you can talk a little bit about that.
I love everything about this. Absolutely. Absolutely. I refer to this as the cultural congruence dichotomy, right? And so in session, if you look differently than me, with the example that you were just sharing,
Mm-hmm.
I am going to ensure that what I say not only is not going to make you uncomfortable, but I want to make sure that what I say is not going to get me in trouble. I'm not going to get hospitalized or whatever it might be.
Yeah.
So although I'm extremely uncomfortable, being that this is my initial session with you, etc., but guess what? I am catering to your perceived discomfort, or I don't even know if you might be uncomfortable, but I have learned as a Black man in the society that I need to make you comfortable, where in reality, I'm the one who's extremely uncomfortable in this therapeutic relationship starting off. And then the other opposite of that applies, where if you look like the person you're providing services to, so Black male with a Black male, there's also this congruence piece where I expect you to get it. So when you don't get it, or you question or deny my experience rooted in my Blackness and racism, etc., it does a special type of cultural injury that is deeper than a white person who did not get it because I expected them not to get it, whereas you of all people should have gotten it.
It's so interesting. And it speaks to, and I read the article that you wrote about the BRA method and using that with your 3 clients, the case studies. And it was something where you really mentioned kind of the really understanding where you're situated and the intersectionality that's happening in the room, and constantly coming back to that and being aware of that. And it feels like, especially in our society and how we treat Black men, that would be foremost of importance, utmost importance for working with Black men. Absolutely. It's that constant reminder and recognition that because of who we are intersectionally speaking, it is always showing up in the space because it's showing up in your life day to day, and my life too, day to day. Yeah.
What needs to change in therapist education that makes treating people like people, wherever their intersectionality is, but especially when it comes to some of the cross-cultural stuff that you and me as educators can start to implement now, but that we need to start looking at systemically to be able to take this nuance, but also take kind of this universal honoring approach to clients in a way that does promote this healing?
I think we need to revamp and restructure our curriculum 100%, right? I think we need to look at what are we included in our curriculum? Is it anti-oppressive, anti-racist, and socially just? Also, is it integrated throughout all of the courses? Gone are the days where we take that one multicultural class and then we're done. It needs to be throughout our entire program so that when folks are finished with their graduate education, they have a keen understanding of what it means to provide effective, culturally responsive, anti-oppressive, anti-racist, honoring-based clinical services to the community, regardless.
So if we're really going to try to look at that very specifically, what are the most important elements in a practice that is anti-oppressive, anti-racist, honoring all of those things? Like where would you start, or where, I mean, I guess the Brum method is kind of where you've started, but like, tell us a little bit more about what actually this treatment could look like. Because to me, when I was reading about the method, it felt like it was very effective for this population, and really is how we should practice with everyone.
Absolutely. I think we should be able to expand, right? Taking the BRA approach to really expand it to all populations and communities. It goes back to what I was saying before. I'm not doing anything new. It's how I'm putting it together to work with a specific population. I think the other piece is we have to listen to the communities to inform our practice. I am all about practice-informed research, practice-informed evidence, etc. Gone are the days where we come up with something and then we do it. It should be in response to the clients that we're working with. And that is guiding how we're providing services to be effective in ways that really honor who they are, intersectionally speaking.
For those of you who only know me by voice, I'm pretty white.
With a glorious beard. A glorious beard.
It is a lovely beard.
And
from one beard to another.
And I point this out in that growing up in a very white part of the country, and just for people who are new to these conversations that may not necessarily be in the socially justice piece of the world, that I can already hear some of the criticisms of, why does this need to be centered on everything? That is, part of this, having a response to an anticipated response here is just kind of, I've heard the evolution of this argument into, well, it's front and center for Black men and women everywhere. And it's something that's faced every day. And then it fits to anybody else coming from a marginalized community that should also be front and center of a lot of these conversations. And I think that there's those of us in this field who are facing this, who are allies, who are doing this kind of work, that have a different space, not only in our clients, but also in the response to our profession in this, in that you as a Black male and a professor and somebody who holds a position of power and obviously important enough to be in interviews and cited in all kinds of things, you've got a great position in this as a leader. For those of us facing the people in our lives and the other people in our profession as allies, is there ways that you recommend us to continue to help elevate these kinds of conversations and to hold our space in it?
Absolutely. I think continuing to use your voices in the spaces that you have most contact with and proximity to becomes important. And doing it in such a way where you're not taking over, right? Liberation efforts. You're not coming in as I'm the white savior, coming in and telling you all other white folks how to ... It's more about bringing that conversation and topic into the conversation in an intentional way, but also allowing people to do their work around this, right? So I always say practice grace in space. Right? We're not beating people over the head. We would hope people will get it and already know it, but we recognize it is not a given for everyone. And so again, allowing for grace and space for people to do their own learning and awareness and reading. I recommend Dr. Ibram Kendi's book all the time, How to Be an Anti-Racist. That's a great starting point. Many folks have joined book clubs and groups and things like that around really taking charge in their anti-racist work. And so I think about start somewhere versus nowhere and continue to sustain that momentum so that it's not, fizzling out over time.
And the direction not to be a white savior, I think is very resonant. I think that there are a lot of folks that's where they feel like they must land. And I know it's something that I'm constantly trying to grapple with myself, because I've, white guilt, all of the things. So
Yes.
I appreciate that direction. I think the thing that struck me in reading your work was this notion that this should be very front and center with our clients as well, that they're aware of our anti-racist, anti-oppressive, kind of methods, mechanisms, the way that we're moving in the world. And I guess the question I have is, how does that show up practically in a therapy space? Like the fact that we are allies, or that we're working every day to be allies, and that we're working to be anti-racist and anti-oppressive. Like,
Great
how does
question.
that, I mean, like without centering our own experience and kind of like, hey, look I'm doing good work over here.
in it, right?
I'm
Cheesy
boasting.
advertisement. Yeah.
Look at me. I'm going to save you, whatever it is. So, like, how does that practically show up for folks who are non-Black, but then also potentially for folks who are Black that are also wanting to put forward, kind of where they sit in social justice and those types of things?
I love it. I think it is important that it comes out at the beginning when you're talking about informed consent, your scope of practice, how you like to do your work, your theoretical orientation, models, approaches. I think it's great to go right into in there. And so it could sound something like, so I am a cognitive behavioral therapist with an anti-oppressive and anti-racist lens. What that means is that as I'm providing ... I also will be intentional at looking at how race shows up and impacts your thinking, your feeling, and your behaviors. Boom. That's enough right there. Done.
Done and done.
Done. You're not taking
Love
up a lot of
that.
space. You're not belaboring the point. You're not trying to get any stickers or a certificate from which, like there's no trophy involved. Perfect. I as a client would be like, wow, oh, okay, come on, CBT anti-racist therapist.
I like it.
Well, and what I love about what you're saying here is that this is another way of extending the action. That it's not just being, that first phone call, like I mentioned with teenagers' parents earlier. It's not just doing it in the first session. It's not just waiting at the end of sessions either. It's being able to say what you're going to do and then do it and show it, not just pay lip service to it, which I feel like, especially hearing a lot of corporate messaging around this, of actually being able to just do it without the expectation of getting that sticker.
Absolutely. It doesn't feel like tokenization. Like, I'm waiting, got my first Black client. Now let me say it, right? Mm-hmm. No, it feels like you want it to come across that this is your spiel, regardless if you're providing services to someone who is Black, African American identified, or Latinx identified, or Asian, Pacific Islander, Native American. Like, this is your spiel that you use every single time that you start off services. And that's why I said it's important that it comes at the beginning when you're talking about informed consent, your theoretical approach and model.
So we've mentioned a couple of times in the episode, and I want to create some space to get into your broad methods. And having looked at what I've been able to look at it online, now being able to talk to you and hear the details of it, I'm excited to hear. So break down what the BRA method is and how that looks in practice.
Absolutely. So BRA stands for Bonding Through Recognition to Promote Understanding and Healing when providing therapeutic services to Black men specifically. And so what I did was I started to get feedback from folks saying, I love your research you're doing. I love, your initial book that you wrote on Black male grief, but how do I do this? And what if I can't attend your training? Do you have some type of workbook or handout that I could have? So that is what encouraged me to write this book. And so I modeled the approach after the other approaches and models that we see very familiar in therapeutic spaces, right? So DBT, CBT, et cetera. And so there are these phases, if you will, that I just named, right? The bonding phase, the recognition phase, the understanding and the healing phases. And it kind of guides you through from the initial, when you start off providing services to Black men, and then all the way through. One of the things that is unique about this particular model is that you're always doing aspects of every single thing, the bonding, the recognition, the understanding, to always promote healing and honoring. I say this is not an evidence-based practice, it's an honoring-based practice. And how you know that you are being effective, your evidence is them continuing to show up, is the feedback they're giving you during your sessions. It's how it's translating in their life day to day. That's your evidence on how effective the approach is for folks who are utilizing it.
So in the bonding phase, it seems like that's where a lot of this identity work and the intersectionality and those things would start. How do you know that you are maybe effectively through have a strong enough bond to move into the other elements of the model?
When they start saying things, they being your clients saying things like, did I already tell you this story? Have I told you that before? You're like, no, right? That lets you know, that's one indicator, right? That they're feeling more comfortable with you, right? Or the consistency by which they're showing up can let you know that, you know what, I think we have a good connection. They're opening up, they're softening in their delivery and how they're sharing things, etc. You're seeing that maybe they're sitting back this time for the first time in session, where the past 3 to 4 sessions, they were sitting at the edge of their seat, not really comfortable in your space. That's information for you, clinically speaking, that you have established enough bonding that you can start moving on to the next phases.
I'm trying to picture this as far as how it works, and especially where there might not be kind of that congruent bonding thing that's almost implicit, the black male to black male therapist, but really in looking at cross-cultural therapy, is there considerations that therapists might really need to be aware of as far as bonding? Because again, for those of us very white folk, we can be very out of touch in a lot of ways. But rather than just being what's going on in pop culture or whatever else, but is there considerations in that bonding approach for working with black male clients that we might not consider?
I think allow time for them just to share how was their experience just getting there today. How was it for you coming to session today? What we know to be true in the work that I've done in research, sometimes just getting to their services, they could have a unique experience, being followed, being harassed. Someone called the police on their way here. Someone maybe wanted to fight them because they looked like they were a threat or whatever it might be. So part of the bonding, what you can do is to begin to ask about their stories just arriving to session. You're showing interest and curiosity on just their experience day to day, but more specifically, just coming into the space. It's kind of like when you ask someone, how's the temperature in the room? How does it feel today? Right? Do you want me to turn it down to right? It's that little communication small talk that really helps people to feel comfortable before we start getting into the work.
So when we're looking at moving the bonds established and we're moving into recognition, what does that mean? Because I know that you said we're kind of in all the spaces. So maybe we go through the RUH at this point, but like, what do those different elements look like?
Absolutely. So when we look at the recognition, the goal of this phase is to honor their experiences of complex trauma based on who they are intersectionally speaking. So what were their losses experiences and grief connected to maybe racism, maybe health or lack of receiving supportive medical services to their health, and their overall just bereavement process. So when we talk about recognition, it's trusting without questioning, judging, hijacking the space, and also ensuring that I get what you're saying. I'm following what you're saying at this time. That's the recognition piece. You don't have to understand it, but you can recognize where they're coming from and how that's showing up.
And paying more than lip service to it. So that way, continuing on in the methods that recognition, creating understanding for clients of their own process, that's not necessarily something that is the therapist, as you've pointed out several times here. It's not necessarily even that the therapists have to get into that deep understanding of the clients, but helping the clients get to their own understanding.
Absolutely. And that's the honoring piece too, right?
It sounds so simple to be present and reflect and just give somebody else their own space and their own opportunity to explore themselves and do it in a way that's non-judgmental and non-shaming.
I know.
And believe them.
And believe them. It is so simple, but because of our own biases, because of our own concerns, fears, it really gets in the way of truly being there and holding the space.
Exactly.
Where can people find out more about you and all of the stuff that you're doing?
You can find me on social media, Instagram at dr.alipscomb, or Twitter at alcombs, that's ALCOMB 101. Or you can go to my faculty webpage at Cal State Northridge. You just type in my name, CSUN, and you will see different articles that I have written, books as well. So one of the books that I was just referencing is The Bruh Approach. You can find that on Amazon. And then also my other book, Black Male Grief Reaction to Trauma, One Man's Mental Health Story. And you can find that on Amazon as well.
And we will include links to all of that in our show notes. You can find those at mtsgpodcast.com. And come and join us on our social media, join our Facebook group, the Modern Therapist Group. We'd love to hear your experiences in working with Black male clients. And if you have additions and suggestions to things that work for you, we'd love to hear about those. And until next time, I'm Curt Widhelm with Katie Vernoy and Dr. Alan Lipscomb.
Thanks again to our sponsor, Superbill.
If your practice doesn't accept insurance, Superbill can help your clients get reimbursed. Superbill is free for therapists, and your clients can use the code SUPERBILL22, that's SUPERBILL22, to get a free month of Superbill. Also, you can earn $100 for every therapist you refer to Superbill. After your clients complete the one-time HIPAA-compliant onboarding process, you can just send their Superbills to claims@thesuperbill.com. Superbill will then file claims for your clients and track them all the way to reimbursement. By helping your clients get reimbursed without the stress of dealing with insurance companies, Superbill can increase your new client acquisition rate by over 25%.
The next time a potential client asks if you accept insurance, let them know that you partner with Superbill to help your clients effortlessly receive reimbursement. Visit thesuperbill.com to get started.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.